My name is Cody Huth, and I'm presenting on the Netherlands and the United States. The United States has a hybrid type healthcare system. Funds come from a mixture of private, public, and household sources. 36.5% of the insured population are covered by the government programs such as Medicare, Medicaid, and military coverage, but the majority of the insured population are covered by a private healthcare plan. The Netherlands, on the other hand, have a universal healthcare plan with mandatory private insurance. The Health Insurance Act of 2006 requires those who work or live in the Netherlands to buy health insurance from one of 14 private companies. The companies are required to accept them at a community-based premium, regardless of their pre-existing conditions. Consumers receive insurance-related government subsidies to help with that cost, and the plan is financed with individuals' annual income-based contributions to tax collector. The employers are required to compensate employees for that contribution. Life expectancy in the United States for men is around 77 years old. For the Netherlands, it's 80. For women, it's 81.5 and 83.5 roughly for the United States and Netherlands respectively. And overall, it's 79.3 for the United States and 81.9 for the Netherlands. The United States ranks 31st in the world, and the Netherlands ranks 14th for life expectancy. The United States in 2016 spent nearly $10,000 per capita on healthcare. The Netherlands was just above half of that at nearly $5,400 per capita. This chart shows how that's changed since 1930. So the blue is the United States, the red is the Netherlands, and the gray in the background are other countries. So the United States has taken off here and gone to the top, far and away above the rest. The Netherlands is near the top as well, but behind their label, they do plateau a little bit, whereas the United States line has gotten steeper in recent years. Flu immunization rates in the United States are about 38.6%. In the Netherlands, it's right around 20%. The reason for such a large disparity is that the United States tries to appeal to everybody to get the flu immunization, whereas the Netherlands has a target population. They target those that are 60 and older, and those that have medical indications such as cardiovascular disease, diabetes, weakened immune system, chronic renal failure, respiratory diseases, or HIV. They do get about 50% of that target population to get immunized. So because they don't target the healthy population under 60, they often do not get immunized. That's why the difference is so big. So a fair comparison could be made between those 65 and older. In the United States, it's about 63.4%. In the Netherlands, it's about 64.6%. So it's pretty even. Tobacco control efforts in the United States really can be summarized by the 2009 Family Smoking Prevention and Tobacco Act. There were other tax rates outside of that tax increases that have helped to control tobacco, but 2009 Act really has done a lot. It put restrictions on advertising, restricts the amount of color, the use of logos, characters in advertising that target towards the youth. It also limits advertising, does not allow it in places that are frequently visited by the youth. The Act also created the minimum age of 18 federally to purchase tobacco. States had their own age at that point. Nearly all of them were 18, some were at 19 or 21, but it did just set that federal minimum. Many states, an increasing number of states, have gone up to 21 since then. The Act also forced tobacco companies to increase the size of the warning labels on their packaging. The health risks have to be more clear. That way people are less likely to make the purchase. The Netherlands really started their tobacco control in 2005 with the ratification of the Framework Convention on Tobacco Control. That set guidelines and provided some initial steps for increasing tobacco control. It really paved the way for the rest of the changes, which in 2013 they increased taxes on tobacco products and created the smoking cessation reimbursement program. It was actually in 2011 they first did that for a year. They brought it back in 2013 and it's still used today. What that does is it forces health insurance companies to reimburse their consumers for purchases that they make to stop their smoking habit. So any medicines that they use, or behavioral therapy, patches, gum, anything that's going to help them stop, they get reimbursed for. In 2014, there was a food service ban that banned tobacco products in food service buildings, and there was also the minimum age of 18 to buy tobacco products. In 2016, they implemented larger warning restrictions, and they created the display ban. Display ban requires stores to put their tobacco products in more discreet places, not as visible to the public, so they're less likely to buy it, specifically the youth, so they don't start using it. In the United States, water access, really 12% of the population cannot afford it. It's too expensive, and that number could rise to 33% by 2020 because of aging infrastructure. The water that we do have is regulated by the EPA. They monitor it pretty closely, so it's one of the safest in the world. The Netherlands, on the other hand, does have 100% coverage, not too expensive. It is top quality. Amsterdam, the capital of the Netherlands, has the highest quality of water in the country and is the safest and cleanest tap water in all of Europe. Water quality in the Netherlands continues to improve through a sustainable water system and integrated water management. Dutch water companies are using advanced technology to turn surface water into pure drinking water without the use of chlorine or fluoride, which is different from most countries. Most countries do use chlorine or fluoride. Their water pipe systems also have less than 5% leakage, which is below all of the others in Europe. They attribute this to their proper maintenance measures and sensor technology. This map shows the at-risk areas in the United States for the loss of access to water. The darker blue shows the high-risk areas, the lighter gray shows the lower risk areas, and then all the areas in white are really at minimal risk for losing access to drinking water. The rate of uninsurance in the United States is about 11.7%. In the Netherlands, it's less than 1%. Big difference there, but the United States put an individual mandate into effect in 2014 with the Affordable Care Act, or Obamacare. This number is from 2017, so roughly 3 years after implementation, whereas the Netherlands put an individual mandate into effect in 2006. This number is from 2014, so it is 8 years removed from that policy. Unemployment rates in the United States and the Netherlands are nearly equal, right around 4.1%. So the Dutch system really can be used as a model for the United States. They had the individual mandate in place before we did. It's something that we can base it off of, move towards. They have lower spending per capita. There are more people that are covered by insurance, and their program is 12 years removed from the individual mandate, whereas we're only 4 years removed from ours. So we can really set our sights on the numbers that they have achieved through that, try to improve, base our system off of them, and work towards those numbers. Less than 1% uninsured is the goal. Tobacco control and water quality for the two countries are kind of flip-flop. Tobacco is a better area for the United States, whereas the water quality is better in the Netherlands. In the Netherlands, about 7% more of the population use tobacco products, and about 5% more of their population dies from tobacco-related illness or disease. However, we are behind in the water technology, mostly due to the fact that most of the infrastructure here was built around World War II, so it's just getting old, and it's going to take a lot of funding to get that up to date and get it to the numbers similar to the Netherlands. The life expectancy is higher in the Netherlands. It's likely because they have fewer people uninsured than the United States. They have lower premiums and copays. It costs less for the general public to get health care. There's also less inequality and disparities among subgroups in their populations, which would attribute to the higher life expectancy.